Okay, so you heard all the guidelines. Huh? You've seen all the guidelines. You've seen the latest technology, and I've tried to put them together in cases. Okay, so this is a 58-year-old patient, nanosTEMI, based on the troponin, which we all use, and look at the ECG. And the patient got enough risk factors to have all this. Now, this patient got a problem of having bleeding if you start antiplatelets. Echo tells you this patient needs, within 24 hours, 48 hours, to do an angiography to see what's going on, okay? So we agree to that. So this patient basically had that, and had it in the way that guidelines say it. You don't put a stent unless you do imaging. If you do a stent without imaging, you're not doing a good service for the patient. Maybe good service for the hospital. Less money, less cost for the thing, but you're not doing. So if you do a stent, do it with imaging, pre, with, and post, okay? So this is the way done, OCT. Anyway, continue the journey. So big stent. So now the question is, sorry, I'm going here, yeah. So what would we do in terms of DAPT regimen? You heard about Dr. Musa, everyone talked about this. Will you aspirin, clopidogrel, cheap, available, or you go with the high, then you think, okay, it should be 3, 6, you have all the data available. So then you're hemodynamic. You're a dynamic person. You don't want to just say fixed one thing, khalas. No, patient come back to you, tells you, take history. Shall I escalate, depend on the finding. This patient basically had I think had a bleeding, yeah? I think had a bleeding, yes. So I forgot. Did I show you that one? He had a bleeding, yes. Oh, I forgot. It's not here. Mild culprit lesion, but it should be a bleeding. Patient basically had a bleeding, and so basically patient hemoglobin dropped. Okay, so we had to make a decision here. What should we do? That's why I'm saying that question. I think the slide is missing here. So the decision was here to put patient on 100 anticoagulant and then decide whether 3 or 6 or 12 months. I think then the patient had bleeding. Sorry, I forgot. So that was the decision. Okay, I know this patient had high risk of bleeding, but despite of that, we said let's go with the aspirin anticoagulant. But then within 40 hours, patient had bleeding. Okay, that you can see hematuria there. It's macroscopic, and you know the patient had a stent. So what should I do? Shall I now consult the urologist, which we should do, or should I stop the DAPT, or should I stop the aspirin, or should I stop the ticagrelor? And if yes, how long? When should I switch? Lots of questions going in your mind. So it's macrohematuria. You continue and even deteriorated over the next 24 hours, dropped hemoglobin from 14 to 11.8. Sorry, there's a typo mistake. So what should I do now? Dropped. There's a bleeding. This is what we did. Okay, we stopped the aspirin. Patient referred to the urologist. Hematuria persists. We stopped the ticagrelor. Resumed the Plavix, clopidogrel, but based on to make sure. Again, one of the problems with the clopidogrel is you don't know if it's going patient to be a responder or not. So patient was a responder. We were happy. We continued that, and patient continued to be on monotherapy. So these things are not mentioned in the guidelines, not mentioned anywhere. This has come from the experience. But are we safe? Is the way to do it? But we have to, because bleeding as harmful as ischemia. So that's the one case. High bleeding risk patient is a dilemma. And we are facing that, whether from GI point of view, from urologist point of view, but then prolonging DAP should be detrimental in patients high risk of bleeding. And early discontinuation might be the safe from the more standpoint of the stent platform. So if you want to put a stent, put it with the imaging. And if you want to do that, then you use the dual antiplatelets, then always reevaluate the patient. If patient had the bleeding, then you go with less potent to prevent the bleeding. Another patient, this patient having bowel cancer, going for resection. So they ask you, this patient for clearance. You say, okay, patient, let me do some investigation. You did echo is fine, but you say, I'm not sure of the patient's stress. So because patient had PCI in the past, I might stop, patient might have an event, let me do a debutamin stress echocardiography. You did that and showed anterior changes. So you did the angio, you found there is a severe lesion in an stent stenosis. Now you want to treat that. You will not treat it without imaging. And you don't treat it without proper tools. Tools should be right here, should be debulking, even IVL used here, properly done, and patient had a nice outcome, and you're sure this stent will not be thrombosed, at least from technical point of view, okay? So that should be the case for the patient. That patient, then you can say, how long I go with antiplatelets? Again, you can say, if the patient need to go for emergency, you need to, of course, think about 1 month or 3 months, not more than that. So last one, this is why it's close to my heart, as Dr. Hussein Hashmat said. This is a young man, come to you for clearance. The patient has got hydrocele surgery, okay? You say, fine, you can go for that. While patient waiting for this, patient had this changes in ECG. So patient in agony, these patients are really having pain when they have hydrocele. So that's the stress of waiting, stress of job, I don't know, whatever. This patient had this event. Came to you, this patient was loaded. This is what we practice, preloaded with this, although the guidelines say something different. So patient taken to the cath, and you can see proximal LAD gone, mid LAD, maybe thrombus gone down. We don't know what's going on. So this patient need to go for operation. What am I going to do? How am I going to fix this case? Okay. So I just go through. This is a diagnostic one. Basically, it tells you a right coronary is fine. Basically, something happened, plaque rupture, proximal, maybe gone down, maybe something else at the middle there. You need some kind of management for this patient. So basically, patient, wired. First, we go to diagonal by mistake. Then we go to LAD. You can see nicely. So there is a thrombus there. Okay, we went with a little bit of balloon at the beginning to see what's going on. Then we brought out this with the aspiration. So the path is slightly clear. Okay, so what am I going to do with this lesion there? It's very long. It looks very long. Is it thrombus? Is it negative remodel? We don't know what's going on. So I need imaging. I don't have imaging that day. Okay, because that's why I don't use a stent, because I don't have imaging. Okay, so this is what happened. I use a DCB here after I managed to clean as much as possible. So it was a long DCB, 2.5 by 40. Then the proximal part, also because fresh, I had a good result with the balloon. You see the balloon is fine. So I had a good result like that. Well, what's the reason for me not to, put a stent? Then this patient might need a surgery. So I was enough with the DCB, even was undersized, was not that big size, because I was worried in case I might cause dissection. This patient came back after 4 weeks or 5 weeks, it says here, because, for some kind of, he was worried, some kind of atypical pain. Anyway, it was a good time to look at that. So this was the 5 weeks after. You see the positive remodeling has happened already to this artery, okay? And there is a bridging. You would have missed this if we would have put a stent. And look at the proximal part, it's fine. It's not ideal, but it's fine. But this patient gone for surgery. Gone for surgery. So basically what I'm trying to say, what guidelines say is something, so it's not a prescriptive. At the end of the day, you are a physician. You tailor your management, your thoughts to that patient in front of you based on the characteristics. And I leave you with this last slide. And thank you very much. Any questions to this one? I actually, this case, I used to give aspirin only for a week, okay, for all my DCB cases. But some of them I started just to continue with the monotherapy, the high potent, with the DCB. No stent thrombosis, no worries, and no imaging, so I'm saving money as well. Right, if no questions, so me and Dr. Professor Rosano really would like to thank you for being with us.